All right, clinic. Today, I think this is Sailor Moon's last chance, but talking about a fun topic, bariatrics. Okay, so bariatrics, that's weight loss surgery. We call it something fancy, but it's pretty simple. Doing surgery to lose weight. There are a bunch of different options for weight loss surgery. We'll talk about all of them. Well, not all of them, but we'll talk about the most common ones. We also got to talk about why we're doing this. We have to address some issues like 1/3 of the adult population in the United States is overweight. We have to talk about 1/4 of the kids between the age of 10 and 18 are overweight. So this is a problem that affects the whole world. But we're focusing on America this time because our BMI requirements for surgery are a little different. A lot of places have socialized medicine. So if you have a BMI of 30 or 35, if you don't have comorbidities, you qualify for surgery. In the United States, we do 35 or if you have comorbidities or BMI greater than 40. But we'll get into all that. So let's talk about bariatrics. Obesity, again, condition being extremely overweight. The way that we talk about this in medicine is by your body mass index. I'll put up the calculation, but it's basically your weight in kilograms over your height in meters squared. When you break that down, you kind of get these ranges that we like to just use to describe patients. So underweight, anything less than a BMI of 18, normal 18 to 24, overweight 25 to 30. They've kind of moved this from 25 to 27 because of an active body style. So people that lift weights, so have a little more muscle than fat. So sometimes someone that's 26 or 27, we won't consider them overweight if they have an active body type. Now, once you start getting into obesity, these numbers always change. But we've simplified them now to where it's class 1, 2, and 3. Class 1, 30 to 34.9, class 2, 35 to 39.9, and class 3 greater than 40. The simple version of this is if you are 35 to 40, you are at risk of developing long-term complications from comorbidities versus if your BMI is greater than 40, regardless of whether you have these problems, your weight is the issue. So this plus this equals a problem. This is a problem, but it presents sometimes, or the reason you have problems is because you can't control any of these other things. 30 to 35, this really just depends on how you look at taking care of someone. In America, we say 30 to 35, 34.9 means you need to diet, you need to exercise, it needs to be addressed medically. It puts you at risk for developing some of these problems. Versus the rest of the world looks at this and says, hey, this person is already on that path. We know that the average person is not going to do diet and exercise enough to lose weight to prevent these problems. These problems cause society a lot more cost. So we need to address this. So that's why 30 with these problems or 35 outside the United States is traditionally used as a means for weight loss versus in the United States, 35 versus 40. Now, everybody always asks, why do you want to lose weight? I have a friend that's overweight and doesn't have hypertension, doesn't have high cholesterol, doesn't have diabetes. Just because they don't have it right now doesn't mean they won't develop it later. This weight loss issue is not just a now issue. It is definitely not a cosmesis issue. It is a health issue. Uncontrolled hypertension is a problem in your 50s and 60s if you don't control it in your 30s and 40s, because you can end up on a transplant list. You can end up having to undergo dialysis. Hyperlipidemia or high cholesterol is an issue even though you can eat as much as you want when you're in your 20s and 30s, because in your 40s, 50s, and 60s, that's what puts you at risk for cardiac disease. That's what puts you at risk for carotid artery disease that can lead to a stroke. So don't think of this as a here and now problem. It is a keep you healthy so that when you're older, you don't have a lot of medical issues. Now, when we talk about risk factors, when we talk about complications of being overweight, this is what we're talking about. Hypertension, high blood pressure. It's not just having high blood pressure. I have high blood pressure or hypertension, and I've had it since I was 21. There's a family history associated with it. The issue when you're talking about obesity-associated conditions is you're talking about poorly controlled or uncontrolled hypertension. So if you walk in and you have blood pressure that's well controlled and your BMI is 35, you're probably not going to be a candidate for bariatric surgery from your insurance standpoint. But if it's poorly controlled and you're having to flip around on 2 or 3 different medicines all the time, that's a different issue. High cholesterol, dyslipidemia, high triglycerides, again, too many fat burgers. Love fat burgers. Shout out to East Atlanta, Earl, one of the best burgers in Atlanta. It's one of my favorites anyway. But this high cholesterol plus hypertension leads to atherosclerotic disease. This is why you have plaques build up in your legs, plaques build up in your arteries, plaques build up in the arteries that supply your brain, and you end up with a stroke. So all of this attributes to that. So from a cardiovascular standpoint, this is one of the main reasons that we focus on weight loss surgery in those patients with a BMI greater than 35 or absolute greater than 40. Now, from a diabetes standpoint, this is actually kind of interesting. Metabolic syndrome and diabetes kind of go hand in hand. Weight loss surgery in take an overweight patient that has diabetes. You give them 3 options: diet control, insulin, or weight loss surgery. So overweight patient, type 2 diabetes. It's crazy, but the diabetic, this type 2, that has weight loss surgery has a better improvement in morbidity and mortality long term than they do if they're on insulin alone. Let me try that again. If you're a type 2 diabetic that is overweight, a sleeve gastrectomy can cure your diabetes. Insulin manages your diabetes. This has been one of the things that the endocrinologists and the surgeons have been fighting about for a very long time because that data is out there. But we continue to manage some overweight diabetic patients with insulin and not referring them to surgery to get it done. Now, yeah, I'm biased because I do surgery, but surgeons, we fix people. You come in with a problem, we want to fix it. Internists typically manage patients. So from our standpoint, we say, why manage something when you can fix it? Now, if you can't have surgery, you're not overweight, yes, you still got to do your insulin. That's no question. If you look at insulin versus doing nothing, yes, insulin is better off than doing nothing. But your type 2 diabetes can be cured or significantly decrease the amount of insulin that you take every time you do it if you have surgery. So talk to your endocrinologist, talk to your primary doctor about it. It's a good option. From a GI standpoint, non-alcoholic fatty liver disease is the #1 cause of cirrhosis in the United States right now because 1/3 of our population is obese. So it used to be back in the day alcoholism, now it's overweight. It's not the same cirrhosis as you see from alcohol. It's a little, it's more benign than alcoholic cirrhosis, but it still causes problems. You can still go into liver failure. When you're 70 and 80 years old, you're not going to be able to tolerate surgery or different medications as well as you can if you don't have this problem. So this is a real issue that we will probably start to pay more attention to in the future. Right now, this cannot be used as an associated condition to get you approved by your insurance if your BMI is 35 to 39.9. Cholecystitis, gallstones. If you're obese, you're more likely to have gallstones. You end up having to get your gallbladder out at some point, whether it's pre-op, post-op, more than likely you're going to have to get it. But again, this is associated with weight. Now, asthma, obesity, hypoventilation, ventilation syndrome. Christine's always putting weird stuff up here. Christine, what's this? OSA?
Obstructive sleep apnea.
Oh, yeah. I'm sorry. So this one, obstructive sleep apnea, I just write sleep apnea. This one is probably the biggest reason outside of type 2 diabetes that we get patients approved by their insurance if their BMI is 35 to 39. Sleep apnea, snoring, is associated with obesity. You can have obstructive sleep apnea without being obese, usually it's central, but you can have sleep apnea associated with obesity, but not with the majority of people who have obstructive sleep apnea, snoring, pausing breathing, stop breathing in the middle of the night, wake up, scare their partner, and then go back to sleep and they don't know anything happened, is because of obesity. So it's interesting that the problems that are associated with obesity are also the things that we use to get people approved if you have a class 2 obese patient and we need to get your insurance to approve this. Now, the other thing is that you don't necessarily have to have your insurance approve you to have surgery. We like that because if you have a complication, because all surgery has complications, your insurance will cover the cost of the complication. But you can always pay cash if you want to get bariatric surgery. If you look at the cost of bariatric surgeries, like for our practice, is $8,900. If you remove the amount of if you remove the amount of food that you eat normally before surgery versus after surgery, and you decrease the amount of medicines, the medicines cost as far as deductibles, it works out to be about a savings of around $4,000. So after 2 years of surgery for the $8,900, you essentially are now making money just by not eating as much and not taking as many pills. So there is a cost-benefit ratio. If you want to get yourself taken care of. Financially, it does make sense. From a health standpoint, it does make sense. Now, to the meat of the issue. What is bariatric surgery? Bariatric surgery in the United States focuses primarily on 2 organs, your stomach and your small intestine. Your stomach is the reservoir for food. So you eat, that's where the food sits, and then it decides how much goes down into the small intestine. Different operations manipulate that stomach to decide if you're full early or not full, if you tolerate food, if you don't tolerate food. Second one, small intestine. The small intestine is the organ that absorbs nutrients. So again, if you start manipulating how well your small intestine absorbs those nutrients, you can then affect weight loss. The biggest way that we manipulate that is by decreasing the amount of time that the intestine has to absorb food. So you'll say have a gastric bypass and say we have a 100 centimeter limb or 150 centimeter Roux-en-Y limb. What we're saying is we're only giving the small intestine X amount of time to be able to absorb food. But we'll get into those details when we start talking about surgery. We addressed this a little bit, BMI greater than 40 or a BMI greater than 35 with at least one serious comorbidity. Hypertension is not it. If you have hypertension, type 2 diabetes that is kind of controlled, that might help. But the type 2 diabetes will count as a serious comorbidity. Obstructive sleep apnea counts as a serious comorbidity. We say adults, but that number has been decreasing slowly. We used to use a cutoff of 18. There's now pretty good data that says that you can start doing these in kids, that if they have a BMI greater than 40 as a child, 13 is reasonable. The other thing that's interesting with kids is that if you are skinny as a kid up until the age of 10, then you have had pretty good eating habits, and more than likely you will make it to adulthood without being morbidly obese. But if you are obese at the age of 10, you will pretty much absolutely be an obese adult unless you have some type of lifestyle change. One more small thing. Whether you do surgery or not, understand that the majority of diets don't work. And the reason they don't work is because people don't make a lifestyle modification. Every one of us who is overweight, it's because we either do something inadvertently and it becomes a habit. So it's whether or not it's you're always finishing your kids' plates because your mom was smacking you in the back of the head when you were a child. You know, you don't think about it, but if you order food and you eat 1,000 calories and you eat 300 calories in chicken fingers because one kid doesn't do it, and then you finish it with some Coke, you've almost increased your calories to 2,000. Maybe you drive past McDonald's on your way to work every day, or you meet your friends at Burger King and you say, hey, let's just get fries, and the next time it's fries and a Coke. Next time, let's drink after work. You have 2 or 3 drinks twice a week, you're adding 2,000 calories. So if you change your lifestyle, that is a quick way to make a diet work. That is a quick way to help surgery work. One of the reasons that some of these work and some of these don't work is because some of them are weight loss operations, some of them are lifestyle modification operations. We'll talk about the difference, but just remember, when you're trying to lose weight, it is about changing your lifestyle, not necessarily just losing weight. Okay, back on the surgery. Multiple bariatric procedures. Everybody wants to name their individual weight loss surgery. I have one that I do sometimes. I used to do a lap band. It was a little different than everybody else, and it worked. Kind of a band with a sleeve. But regardless, these are the top 3 plus, and then there's some other pluses down here. The top 3 kind of not necessarily rotate, but they all had their moment in the sun. We used to do gastric bypasses a lot, and then we went from bypasses because of the complications associated with it to lap band. Lap band was great because it didn't have as many complications, but it was surgeon specific. So now we've gone primarily to sleeve gastrectomy. So that's the most popular one right now. Sleeve gastrectomy is essentially making your stomach the size of a banana. So we remove almost 2/3 of your stomach and you eat less. It's a restrictive operation. It is truly a weight loss operation. You do that, more looks like, just because I'm a weirdo, it looks more like that. You can lose anywhere from 60 to 150 pounds depending on your weight at the time of the procedure. You eat less, you lose weight. It's that simple. Now, for some patients, that doesn't work. Some people that have large hiatal hernias, some people that have severe reflux, they can't tolerate a sleeve gastrectomy, especially if they have some esophageal problems, because you're creating a zone where food slows down, and that sometimes can reflux up. If you have a hiatal hernia, we fix it at the same time you do a sleeve gastrectomy. And this probably works 90-something% of the time. So we're not talking about 50-50. 90% of the time, most patients now with weight loss are going to have a sleeve gastrectomy. The nice part about a sleeve, with regards to at least a gastric bypass, is done by someone who knows what they're doing. The sleeve gastrectomy has a morbidity and mortality similar to an elective gallbladder, an elective appendectomy. So it's a relatively low risk. If done by someone who knows what they're doing, you have appropriate preoperative and postoperative follow-up. I like this procedure. It works great. It takes anywhere from 30 minutes to an hour in the operating room. Patients have great results, and they don't have that rebound weight gain that you see sometimes with a gastric bypass. When they do this, they lose weight, and it usually stays off if they're not doing anything like drinking alcohol or eating ice cream all the time to get past the restrictive process of the stomach. The main reason we went with this operation over a gastric bypass is a gastric bypass is a little different. So what we do, instead of doing any restrictive process, what we do is we cut off the top part of your stomach and we make a little pouch. So when you do that, this is no longer attached to your stomach, and you can see why Christine draws and I don't. We then come down here and bring small intestine to connect here, and this goes down to the rest of your intestine. So when you eat, food comes down this way, and this is usually 100 centimeters or 150 centimeters, and then the enzymes from your pancreas come here, and then that's when you start absorbing nutrients. So you're losing weight because, and this is why they call it a Roux and Y, because it looks like a Y. You've taken this limb and you've removed 150 centimeters of small intestine to absorb food, and you've also created a small pouch. You can lose 80 to 150 pounds plus 200 pounds. You can lose a lot of weight from a gastric bypass. But there are two issues with this, and these issues kind of focus around the pouch and this 150 centimeters. The body's pretty cool. That's one of the reasons I went into surgery. It's cool because it can figure out most stuff. So with a gastric bypass, after 2 years, your body usually figures out the malabsorption issue, and it kind of changes that distal small intestine to become more efficient. We've seen this in short gut patients where we have to take out small intestine because it dies or whatever, half of it, or leave them only 1/3 of their small intestine. After 2-3 years on TPN, their body says, oh, okay, we need to become more efficient, or it switches some of the absorption to the stomach or the colon or whatever, but it figures it out and you start reabsorbing food. So most patients after about 2 years from a gastric bypass, if they haven't changed their lifestyle, again, lifestyle modification, they'll start to gain weight back again. So you'll see patients that'll lose 150 pounds, and then over the next 2 to 3 years, they will gain some of that weight back. So you may lose from 300 to 200 pounds and then gain 50 pounds back. Some people gain more back because they've actually gotten worse lifestyle options during that time because they said, oh, I can eat what I want, and I still don't gain weight, and they just got into bad habits. If you look at the data, it says about 60% of people after a gastric bypass can gain their weight back, or they gain 60% back. But it's a good operation in someone that needs to lose weight very quickly because of comorbidities, or someone that needs to lose a lot of weight really quickly to get another procedure done. The weight loss from a gastric bypass is a lot faster than it is for a sleeve. But I think a sleeve has better long-term weight loss options. Also, gastric bypass as an elective procedure has the morbidity and mortality similar to emergency cardiac surgery. So there's a chance that you will have serious problems after a bypass. We have plenty of patients that have done well with bypasses and have no issues. The other thing for a bypass versus a sleeve, sometimes we use a sleeve as a bridging procedure. So if you have someone that weighs 400 pounds, you know, if we do a sleeve on them alone, they might get down to 300. If they have real bad heart disease, if they have pulmonary hypertension or something like that, you can do a sleeve first, get them from 400 to 300, and then turn around and do a bypass and get them from 300 to 200. So it's sometimes not just we do the sleeve, we kind of say, okay, do a sleeve first and do a gastric bypass. Now, the third operation, lap band. Lap band is a little different as well. A lap band, let's get rid of all this blue stuff. A lap band is nice because lap band was better than a bypass in the fact that the risk of having problems with it was a lot less. So it had a lot less risk profile. What it is an adjustable band. We put a port here in your stomach, tunnels up to the top of your stomach, and there's an adjustable band that goes around. What it does is it truly is just a restrictive procedure. When you have a lap band in, if you lose 25 pounds, we come in and adjust you, you lose more. If you're losing too much, we can take some fluid out of the port and you lose less. The nice part about a band is it is adjustable, which means I can tailor you to whatever weight loss profile you want. If you want to lose 20 pounds, cool. 50 pounds, cool. 75 pounds, cool. But you are looking at just restriction and you're making a small pouch. Some people get bad reflux after a band because you're really talking about maybe 5 centimeters down from your GE junction or where your esophagus and your stomach join. So it's a small pouch. So a lot of people complained about that. For whatever reason, men traditionally tolerated a band better than women. Can't tell you why. It's just, it is what it is. The problem with a band is a lifestyle modification operation. It is not truly a weight loss operation. If I put a band in someone, they'll lose 25 pounds average. And that's it. They won't lose any more. They won't lose any less. It'll be about 25 pounds. They will not be as hungry as they are right now without a band, but that's it. In order to lose weight, you have to come in and get adjusted. So we've now removed some of the responsibility of the surgery and put it back in the patient's hands. If your BMI is 30 and you want to get down to 27, that's a great option because once you get to 27, take some of the fluid out and we can keep you right there. But if your BMI is 40, you've got to do a lot of coming in, you've got to do a lot of adjustments, and you have to participate in this process. And what we found is that a lot of patients that were morbidly obese weren't willing to come in and weren't willing to get adjustments as much as we, the medical community, thought they should. So we didn't see the weight loss that we saw with a gastric bypass. Gastric bypass, man, a month after, they've lost 30 or 40 pounds. It's because you're starving them. I mean, essentially that's what you're doing. With a band, they were losing maybe 10, 15 pounds in the beginning, and it was slow weight loss until you got them adjusted to the right point, and they would lose 2 to 5 pounds every month once you got them to the correct place. Now, bands do migrate, happen sometimes. That is surgeon specific. Some surgeons' bands, when they put them in, they migrated a lot. Some of them didn't. There were 2 types of bands on the markets, but they were pretty much the same. I like one over the other. I use a lap band system as opposed to the other system, but both of them or some version of them have been in patients since the 1960s. So they are long-term survivors in patients. They don't have any problems. They can erode over time, but that's usually an acute problem, not something that happens 10, 20, 30 years. So if you have a band in and it works, leave it alone. Got it? Cool. When did it stop?
Just a couple of seconds.
Oh, okay. Did I finish lap band or not? Mm-hmm. Okay, cool. Hey, Jen.
I look like a dwarf.
Right. What's up?
I look huge.
Yes, hi. Good day, George Crawford.
Go all night.
Girl, yeah.
Listen,
What's up?
so I had this little lady that had the pancreatic cyst.
Yeah.
We did a 6-month CT.
Yeah.
Then they recommended the MRI.
Yeah.
And then 6 months again. Do I
Right.
need to do the MRI again? Or
CT.
do a CT?
Just do CT.
Okay.
Okay.
Thank you.
So, last one, duodenal switch. This is, I'll put a video up about duodenal switch. It's a weird operation. It works very well. It kind of is restrictive / malabsorptive. It's kind of like a bypass, but fixed a lot of the problems that you have with a bypass. This is really more of a specialty operation. You'll find a few surgeons that swear by it and do it, but I think a lot of times it's overkill. Now, if you're a super obese patient, it may be a good idea, but for the most part, I personally would say do a sleeve first and then convert to a bypass. The last part of bariatric surgery is the non-surgical weight loss. So we're looking at the Obera, which is a balloon that we use, blow it up in your stomach. It actually is pretty cool. They took a breast implant, put a weird valve on it that you can inflate it, and then they basically put it in your stomach via endoscope or EGD, blow it up, you leave it in for 6 months, and then you go back, pop it, and pull it out. It actually works. The problem is the insurance doesn't cover it, and it is traditionally temporary. So patients will lose 10, 15, 20 pounds on it. They don't have to have surgery, but it costs around $6,000 to $6,500, and it's not covered insurance. So $6,500 for 15, 20 pounds of weight loss versus a sleeve at less than $9,000 for real weight loss that's permanent. So it's not caught on, but if you're trying to have a mommy makeover and you need to lose 15, 20 pounds and you won $1.3 billion in Illinois, you can send me some money if you want to. But if you lost, if you have that kind of money and it doesn't make a difference, fine, go for it. We also have some endoscopic sleeves, as they call, where we're doing some imbrication of the stomach via scope or EGD to shrink the size of the stomach. Realistically, they all work. Some are better for some patients, some are better for others. At the end of the day, whether you do a sleeve or bariatric bypass, do it in a switch, whether you pay cash or whether you do insurance, the whole point is to keep you alive. One of the best pieces of information someone gave me about gastric bypass, and it stuck when I was doing one of these courses, where we kind of always do refresher courses or CMEs. They said that if you are morbidly obese and you do a weight loss operation and it goes well, you add 10 years to your life. So that means if I'm morbidly obese and I was supposed to die at 70 from a massive heart attack, I may be able to live to 80. Or if I was going to have a problem at 60, I'll live to 70. So we're talking about adding years to your life. We're talking about saving money. We're talking about less hospital visits. So it's something you really need to consider. Hope that answers all your questions. As always, DM me, call me, text me, Instagram, all that good stuff. All right, guys, take care. All right, questions. Y'all got any? Sure? Y'all good as medical students? Y'all good? No questions? Everybody's good?
Good.
All right, cool. All right.